Okay, it is just a few minutes after the top of the hour, so we will go ahead and get started because I'm sure we have a lot of information to cover, as we usually do on these topics. So welcome everybody. I'm Molly Brown from the Heartland Telehealth Resource Center. We're glad you're joining us for the HTRC education series focused on telehealth billing, coding, and policy. Just a few notes. This session is being recorded and we'll share it with you afterwards. Your microphones have been muted. Please unmute or use the chat to talk. We typically like to use the chat box during these webinars because they are so packed with content and information. Keep in mind, if you ask a question in the chat box and we don't get to it during the webinar, we always follow up with your answers or additional resources in our follow-up email. If you would like a completion certificate, please contact us at htrc@kumc.edu. We will put the email in the chat, and we'll make sure that you get your certificate shortly after the webinar. So let's get started. I'd like to introduce Rochelle Martin. Rochelle is a local attorney who is also a registered health information administrator and a certified medical coder. Her practice focuses on medical coding, billing, and reimbursement, HIPAA privacy, and regulatory compliance. We're thrilled to have Rochelle with us today to talk about the pre-PHE DEA rules, temporary flexibilities created during the PHE, and the DEA's current position on prescription of controlled substances via telehealth and its regulatory wind-down timeline. Now I will turn it over to Rochelle.
Okay, thank you, Molly. Just making sure you can hear me okay and you can see my screen. Perfect. Okay, we'll advance the slides, and without further ado, we'll dive into the content for this afternoon. Thanks so much for joining. This has been one of probably the most common questions that we got through the HTRC email throughout the PHE, and particularly as we were nearing the end of the public health emergency, folks wanting to know what was going to happen with respect to rules and flexibilities surrounding prescribing medications, particularly controlled substances, during telehealth visits. So I want to start a little bit because it has been so long since some of these rules, our pre-PHE rules, were in effect, with some basic prescribing rules at state law, even outside of the DEA and even outside of controlled substances, just some basics that are going to apply in prescribing medications via telehealth, and that still exist at state law. And we'll talk about the Ryan-Haidt Act. It's been around for a while at the federal level, and the DEA is one of the agencies that implements the regulations to carry out the Ryan-Haidt Act statutes. And then what happened during the public health emergency. In particular, we're going to focus at the end on what was happening right before the public health emergency ended with respect to the flexibilities surrounding prescribing controlled substances during a telehealth visit, and where we are today. So we're going to start with some basics about prescribing medications in the course of a telehealth visit. And I'm going to focus on our 3 states for this, this resource center, so Kansas, Missouri, and Oklahoma, and their state laws. I'm going to try as we go throughout this to differentiate and explain the impact that it means to have a state law versus a federal regulation versus a payment policy rule. But use the chat if you've got any questions about how these things all tie together. So at a very basic level, our state laws largely lay the framework from a licensing perspective for healthcare professionals on when and how they can prescribe medications during a telehealth service. First and foremost, you want to make sure that the provider who will be rendering the telehealth service has the appropriate licensure in the state where the patient is located. That's the preliminary consideration that we want to think about. Now, in states like Kansas, Kansas has sort of an expedited licensing process for providers who will be exclusively rendering telehealth services to patients who reside in Kansas at the time of service versus a full-blown license to practice medicine. That's under the Board of Healing Arts. Not every professional licensure board in the state has that option. So that's really just for physicians and those licensed through the Board of Healing Arts. And that varies from state to state, what those requirements look like. So once you know that the provider is licensed in the state where the patient is located, where a telehealth service will be provided, then we talk about rules on how a provider-patient relationship can be established. This is a state law rule. And usually it's defined by state statutes when it comes to telehealth services. So in Kansas, for example, telemedicine can be used to establish the provider-patient relationship. Missouri, and I'm kind of looking over at my notes here to make sure I get the language exactly correct. In Missouri, before prescribing any drug, any medication, or controlled substance, through telemedicine, the physician has to establish a provider-patient relationship with the patient. Now, that can be done via telehealth in Missouri as well. But there are some caveats where Kansas is just broadly saying you can establish the provider-patient relationship via telemedicine. Missouri gives us a little bit more criteria. First of all, that telehealth visit has to be within the standard of care. There's not a great definition for that in the statutes. It's really up to the individual professional to decide. He or she can render that professional service appropriately based on the patient's condition and the treatment needed. In Missouri, in order to establish the provider-patient relationship during a telemedicine visit, the technology used has to be sufficient for the provider to establish an informed diagnosis. Now, I put this in italics as though the interview, the history, and the physical exam were performed in person. It does not say that the history and exam must be performed in person. But the provider has to feel comfortable that with acceptable standards of care, the provider was able to evaluate the patient sufficiently, including an exam via telehealth if appropriate, to establish an informed diagnosis. Now, Missouri is specific to say an internet questionnaire by the patient is not enough to establish a provider-patient relationship that would allow a provider to prescribe medications during a telemedicine visit. Now, Oklahoma goes into a lot more detail in its statutes in terms of what can and cannot establish a provider-patient relationship in the course of telemedicine. So in Oklahoma, the statutes and the regulations explain that telemedicine visits in the state of Oklahoma, and that means where the patient is located, not necessarily where the provider is located. And those telemedicine encounters shall not be used to establish a relationship with the patient for the purpose of prescribing opiates, benzodiazepine and substance use disorder medications, unless a lot of kind of caveats there. So if the telemedicine encounter is for some other purpose rather than just to prescribe opiates or certain substance use disorder medications, then this is not limiting the ability to establish a provider-patient relationship via telemed. If the encounter is for the purpose of prescribing those types of medications, some specific things need to happen to establish the provider-patient relationship. Certain types of medications, so opioid antagonists, a Schedule 3, 4, or 5 under the Federal Drug Enforcement Administration Controlled Substances Schedules, approved by the FDA for detox or substance use disorder. Now, also important to keep in mind, at state law in Oklahoma, there is a licensure rule for physicians that says unprofessional conduct for a physician licensed in the state of Oklahoma includes prescribing or administering a drug, a medication, or other treatment without a sufficient examination, without establishing a provider-patient relationship, and not doing that in a safe, medically accepted manner. But I put the phrase sufficient examination in bold because it does not say that unprofessional conduct means providing a telehealth service without an examination, without an appropriate examination, because there's a lot that can be seen and examined objectively during a telehealth or telemedicine visit without being physically in person and face to face. So the exam, the history in the exam has to be consistent with what you would do to diagnose the patient's condition and prescribe a medication in a safe and effective manner. And then Oklahoma has a prohibition on prescribing abortion-inducing medications directly to the patient through mail, through telemedicine, or otherwise. So that's establishing the provider-patient relationship. And I kind of, with Oklahoma, got into the in-person exam requirement, but I want to look at that in Kansas and Missouri as well. So in Kansas, I've got an X in green, meaning you do not have to have an in-person examination for a patient located in Kansas prior to a telehealth visit where medications will be prescribed. And in Missouri, you don't either from a licensing perspective, but from a payment perspective. I've got a link on the slides that you'll be able to access when we send these out after the session, that there is a Medicaid policy update for certain community behavioral health services rendered in the community that does create a very limited scenario when an in-person visit might be required from a payment perspective. So that's our state law. From a licensing perspective, from a creation of a provider-patient relationship perspective, what has to happen before medications generally can be prescribed in the course of a telemedicine visit? So now I want to shift gears and talk about the Ryan-Haidt Act. This was a federal law that was passed in 2008, I believe, and it was really designed to prevent the prescription of controlled substances by providers to individuals that they had never seen, that they'd never examined, and essentially providing those prescriptions in an unsafe manner that might cause patients harm. And what the Ryan-Haidt Act did is give the Drug Enforcement Administration and the FDA the authority to create regulations to carry out those rules. So they generally, there are some exceptions, but generally require an in-person, not telehealth face-to-face, but physically in-person visit between a practitioner and a patient before prescribing controlled medications during a telehealth visit. Now, so this I want to pause again and kind of talk about the relationship between those state law rules and this federal statute and federal regulations, okay? These federal rules affect DEA registration, DEA licensure for providers to prescribe controlled substances. The rules we talked about at state law, those are professional licensure standards. Those are professional rules for the practice of medicine and other professional services. So that might impact the MD or the DO's license to practice medicine, while the Ryan-Haidt Act impacts their ability to prescribe controlled substances under the DEA. And you could have one without the other necessarily. You could be licensed to practice medicine without a DEA registration. Neither of these are payment rules. So these are not rules that an Aetna, Blue Cross, Cigna, Humana, United say in order to be paid for services, certain things can or cannot happen. These are just licensure and registration rules. So the Ryan-Haidt Act at a very high level, when this was passed about 15 years ago, says that no controlled substances, the way that's defined under the DEA and the Controlled Substances Act. No controlled substances can be delivered, can be distributed, or dispensed through the internet without a valid prescription. Okay, so that's mail order, pharmacies, and scripts. We have to have a valid prescription. So then it goes on to explain what a valid prescription is. A valid prescription is one that's made for a legitimate medical purpose, okay, so consistent with the standard of care in the course of professional practice, okay. Now here's the piece that I think starts to get interesting: by a practitioner who has conducted at least one in-person evaluation. Or a valid prescription could be by a covering practitioner. Now I have a practitioner and later on the practitioner bolded because these are two really important terms that we're going to talk about in what the DEA is currently weighing with some proposed rules about what these terms mean. Any practitioner who has conducted an in-person evaluation versus the specific individual practitioner. And those can make a difference on who can do what. So that's what a valid prescription is under the Ryan-Haidt Act. We can only prescribe medication for legitimate medical, prescribe controlled substances for a legitimate medical purpose in the normal course of business by a practitioner who's had an in-person evaluation or a covering practitioner. And in-person and face-to-face can have different meanings depending on what state or payment rules we're talking about. For DEA and controlled substance prescription purposes, in-person means physically in-person, face-to-face of the practitioner who's issuing the prescription. A covering practitioner who could issue a valid prescription for a controlled substance, which could be prescribed in the course of a telemedicine visit. That covering practitioner can be someone who is evaluating the patient at the request of another provider. And that other provider is temporarily unable to evaluate the patient or is unavailable. And the other provider, the requesting provider, has conducted at least one in-person, physically in-person evaluation of the patient, or there's been an evaluation through telemedicine within the previous 24 months. When those things have happened, a covering practitioner can prescribe controlled substances for a patient during a telehealth visit. So those were our pre-PHE limitations at a federal level from a federal prescription level. Let me back up one step again and go back to Kansas, where we said a provider can establish a provider-patient relationship via telemedicine, and medications can be prescribed via telemedicine. So if that's the state law rule, and a provider is having a Kansas telehealth visit and wants to prescribe controlled substances, the more restrictive federal controlled substances rules are going to come into play and will still apply, even though Kansas state law might be less stringent or less specific in the way that they're worded. The same for Missouri, the same for Oklahoma. The more restrictive, the more stringent of the two requirements is going to be what applies. So, of course, then we enter into 2020, and we've been working under the Ryan-Haidt Act for 12 years, and now patients may need prescriptions for controlled substances who may not have seen that provider in person, physically in person yet. During the public health emergency, the DEA as an agency had sort of broadened powers to do things that might conflict with federal law under the Ryan-Haidt Act that was passed by Congress. And the DEA had these broadened powers to make things more flexible for the duration of the public health emergency. But those powers go away from an agency perspective when the public health emergency ends. And then we again are left with federal laws. So the DEA exercised that authority and waived that initial in-person visit requirement before a controlled substance could be prescribed in the course of a telemedicine visit. And that's the role from a federal level that we were able to operate under from a DEA licensure perspective throughout the course of the public health emergency. That in-person exam during the course of the federal public health emergency from a DEA controlled substances prescribing perspective says that no in-person visit was requirement if, you're going to see a trend here, the prescription was for a legitimate medical purpose, providers acting in the usual course of their professional practice, and there had to be an audio visual two-time real-way communication, not phone only, not e-visits that are done through email or portal messages, a live telemedicine with a visual component to it before a controlled substance could be prescribed for that patient. So that continued for the duration of the public health emergency. Then we get to early 2023, earlier this year, and there were signals that the public health emergency was not going to be renewed as of May of 2023. So at that time, we started to see federal policies start to be announced on what was going to happen on May 12th at 12:01 a.m. in our first day of the post-COVID PHE era. What were the policies for telehealth and for prescribing controlled substances going to look like? So in March, the DEA publishes what they propose prescribing controlled substances via telemedicine might look like once the public health emergency ended. Now, at this time, when the proposed rule was released, we didn't know yet that May was going to be the date. It could have been extended for another 90-day period. So this rule comes out, and really what the DEA was focused on is a paragraph in the Controlled Substances Act that says the agency can, by regulation, determine other ways that controlled substances can be prescribed via telemedicine. So it's kind of a broad authority to make the rules and set the safeguards and parameters. So using that as the flexibility, the DEA comes out with this proposed rule. If anybody wants to read it, when the slides come out, there will be a hyperlink to it. And this is what was proposed, and I want to emphasize these are proposed rules. These have not been finalized. This is just what is still on the table that the DEA is considering. And the DEA said they would authorize telemedicine for purposes of prescribing controlled substances under certain circumstances where the prescribing practitioner, that exact individual, may not have conducted an in-person evaluation with the patient, and the prescriptions being made via telemedicine, and the prescription is for a controlled substance under certain circumstances. So those circumstances, in order for that to happen, were that the prescription has to be made in accordance with state and federal law. So Oklahoma, if your state is more restrictive as to when a provider-patient relationship is established and when medications can be prescribed during a telemedicine visit, no matter what the DEA does, your more restrictive rules in the state of Oklahoma would govern. So we have to follow accordance with state and federal law in issuing the prescription. The practitioner who is issuing the prescription has to have an active DEA registration where the practitioner will be located. These are proposed rules again, but I think that's important because it's sort of the reverse of what we've been used to, where the provider has to be licensed in the state where the patient is located from a licensing perspective during telehealth. And this proposed rule, if finalized, says they have to have a DE registration where the practitioner is located during the time of service. So if they provide a telehealth visit while on vacation, while at a conference or things like that, that could restrict the prescription of controlled substances via telemedicine if this rule were to get finalized the way it's written. That ability to issue a prescription for a controlled substance during a telemedicine visit without an initial in-person visit prior to the script would be limited to a 30-day supply. Then, when that initial supply is given, the proposed rule would still require an in-person evaluation within 30 days of the script being given. It just gives a little bit of flexibility to get the patient the medications that they need and then to bring them in for a visit. Now, I want to put in kind of an asterisk or an emphasis on that bullet point because it was an area that the DEA was specifically seeking public comment on whether the 30-day supply was the right number. Should there be some alternate duration for the prescription before the patient comes in? And we don't know yet what the DEA will do when they issue a final rule. But that might be one area where we could see changes. It would also require on the script itself, whether that's a hard copy script or an electronic order for a prescription, there has to be a notation that the prescription was issued in the course of a telemedicine visit. From the different things I'm reading about the DEA's consideration of these proposed rules and the public commenting, that last provision may be something we can expect to get finalized. So this may be something to start thinking about now. How would you do this on your paper scripts, or if you use electronic orders and prescriptions for all of controlled substances, where in the system is there the ability, or how would you make the notation that the script was issued via telemedicine? That's going to be a requirement in order to avoid licensing issues under the Controlled Substances Act. Those are individual practitioner licensing requirements that they don't want to run afoul of, and we want to help make sure our practitioners understand exactly how they can meet that requirement to protect their DEA registration and license. Now, there is one alternative to this italicized language that an in-person exam would be required within 30 days of issuing a script for a controlled substance during a telemed visit if an in-person visit didn't happen before the telemed visit occurred. And that exception that is proposed, or that alternative that's proposed, not finalized yet, is that if the prescribing practitioner receives a qualifying referral for the patient, that provider may rely on the referring practitioner's in-person medical exam in order for the telehealth provider to issue a prescription. That allows a lot of practices who might be completely remote a mechanism to prescribe and maintain prescriptions for controlled substances if they're getting an order from a provider who had an in-person visit. Again, this is proposed, it has not been finalized. Then that March proposed rule, which still has not been finalized, also addressed how non-narcotic controlled substances might be handled. And there's a new term called a telemedicine prescription that would be created. And it says that a script for these Schedule 3 to 4 non-narcotic medications arise out of a telemedicine communication directly between provider and patient. The practitioner is physically located within the United States at the time the prescription is made. Practitioner has appropriate DEA registration for the script, no surprises there. And again, the prescription itself, either hard copy or electronic, has to specifically note that's being issued based on a telemedicine encounter. It also requires that the provider review prescription drug monitoring programs in the state where the patient is located before these scripts are issued. So I always, when I'm looking at these rules, thinking about what it means from an operational perspective and what it means from a documentation perspective. And this last bullet point tells me that we need to be thinking about where and how the provider issuing that prescription during a telemed visit will document that they reviewed the drug monitoring program in the state before making the prescription. We want to make sure that that is captured somewhere so that there is no question that that requirement had been met. Now, in the March proposed rule, the DEA was also considering a special registration process that might allow providers to prescribe controlled substances during a telemedicine visit without an initial in-person visit, without having to go through some of these different caveats. And in other words, sort of a blanket permission under certain circumstances. For example, if the patient was located in a rural area, the DEA considered, could we have a registration process that would allow certain providers with that DEA registration to issue those scripts via telemedicine without an in-person visit if the patient's in a rural area? The DEA decided against proposing that type of special registration process, mostly because the DEA felt like the access issues to prescribing controlled substances were not just limited to rural areas, but it was one that they considered. They also thought about whether they could do a similar special registration process when the patient was located at a qualifying originating site. So if you think about regular telemedicine rules, originating sites before the PHE were things like provider clinics, hospitals, critical access hospitals, community mental health centers, skilled nursing facilities, where the patient was physically located at the time a telehealth service was rendered. One of the challenges I noticed right away when I was looking at the way the DEA thought about implementing this special registration that would allow the prescription of controlled substances during telemed without an initiating in-person visit, when the patient was located at an originating site, the list of originating sites the DEA considered was not the same as the eligible originating sites for regular Medicare's telemedicine visits. So that, I think, would have created a lot of confusion and a lot of potential compliance issues. So as a result of considering several different options, the DEA said at this time, they're not proposing a particular special registration process. That doesn't mean they won't create one in the final rule, because they are accepting comments from the public, or did accept comments from the public as a result of that proposal. And it could be implemented, but I think that's probably unlikely. As if all of this weren't complicated enough, there is an entirely separate proposed rule from the DEA on how prescriptions for medications and narcotics for maintaining and detox of substance use disorders are made via telemedicine that are running alongside these proposed rules. So that proposed rule came out in March, and the public always has 60 days. Well, I shouldn't say always, usually has 60 full days to look at a proposed rule and to submit comments before a final rule is issued. That would be really fast rulemaking. And the challenge with that proposed rule coming out in March is that a few weeks later, weeks or months later, we had a pretty good indication that the Department of Health and Human Services was not going to renew the public health emergency again. And so on May 11th, we were receiving communications that there was an intent that the PHE was going to expire. And in other words, we would have barely enough time for the public to get their comments in, and that would have given the DEA 10 whole days to read, review, and prepare final rulemaking from those comments. As we stand today, the DEA still has not finalized that rule. So what they did instead, to avoid kind of a gap or an access issue for patients who had been seeing their providers and been receiving their prescriptions for controlled substances via telemedicine for 3 whole years at that point, a little longer than 3 years, the DEA created a temporary rule that extended that ability to see patients via telemedicine, issue prescriptions for controlled substances through November 11th of 2023. That was the first temporary extension. And just recently, because we're getting close to that extension and still didn't have a final rule, or getting close to that deadline, the DEA issued a second temporary extension. Now, this time, extending all of those same flexibilities to prescribe controlled substances via a telemedicine visit without an initial in-person visit through the end of 2024. And again, this is a licensing rule. It's not a payment rule, but it's a licensing rule that allows us to do that. Now, just recently, September 12th and 13th, the DEA held public listening sessions to get testimony and opinions and input on their proposed rule. So when we send the slides out, you'll get a link to the site if you enjoy reading things like public committee hearings. You can pull up the transcript, or you can watch the videos of those DEA listening sessions, and you can kind of get a sense of what the different perspectives are. And sometimes by listening to the questions the agency asks, you can get a sense of the direction that they might be looking for future rulemaking. But as of right now, we've got an extension through the end of 2024. So specifically what that's doing through the end of 2024, all DEA registered practitioners can prescribe schedules 2 through 5 controlled medications via telemedicine through the end of 2024. And here's an asterisk, as long as it is consistent with state law. So we still have to be licensed in the state where the patient's located. We still have to ensure we're establishing a valid provider-patient relationship and following all of those state law rules. When that happens, this is the DEA's flexibility through the end of next year. Okay, I'm going to pause there because that's a lot of information on where we are and where we're going. All of that to say, as of today, there are no final rules on what the DEA is going to do beginning January 1 of 2025. But this does explain kind of where we are today. So I'll pause there and see if we had any questions, Molly, in the chat that came in.
We have not had any come in via the chat, but we do have a little time. If there's anybody that needs to ask a question, can unmute and ask Rochelle. I'm not hearing or seeing anything right now. Couple of items I'll go ahead and follow up with just to make sure you have the information. And in the meantime, if you do have a question, just let us know. We do have another webinar coming up on November 15th at 11 a.m. and we will be covering the final physician fee schedule, kind of a follow-up from our webinar in August, I believe it is in August. So a reminder, you can check out our recorded videos on our YouTube channel, and you can always contact us through our email address. And Haley has put that in the chat for you to keep for your records. So again, we will have another webinar on November 15th. So be on the lookout for that calendar invitation in your inbox. And I think if we don't have any questions, I think that's all we have for today, Rochelle.
Okay.
All right, once again, thank you for joining us. Also visit our website for additional information and resources, and give us an email if you have any questions or thoughts that you kind of ponder on after our webinar today. We appreciate your time and look forward to seeing you next month.